Well, welcome to H360 Health Talk. Today we're joined by two guests from RWJBarnabas Health in Hamilton, New Jersey. Joining me today is Dr. Samir Desai and Vivian Owusu-Mensah. Thank you so much for joining me. So Vivian, being a nurse practitioner, I know how busy you are in the hospital, and I greatly admire the nurse practitioner profession. I believe you're the backbone of our healthcare system. Can we start by having you just tell me a little about yourself?
Oh, yes. I'm the nurse practitioner for the lung and thoracic program at RWJBarnabas Health Cancer Center at Hamilton.
And Dr. Desai, you're a hematology oncologist, and can you give me a little background on yourself?
Sure. Yes. I'm a medical oncologist, and I work for Regional Cancer Care Associates. We have several offices, but we provide the medical oncology services for RWJBarnabas Health at Hamilton. We have 8 physicians there, and we do both inpatient consultations and outpatient evaluations. And we work together with a team of specialists from Cancer Institute of New Jersey, including thoracic oncologists, pulmonary doctors, and radiation oncologists.
Well, November is a very important month for you, being that it's Lung Cancer Awareness Month. Can you give me some idea of the prevalence of lung cancer?
Yes. Lung cancer in the United States is the second common cancer among men and women. It is the leading cause of cancer death among men and women age 50 and above. And according to the American Cancer Society, every year there are over 228,000 new cases and over 142,000 deaths. So, meaning that lung cancer claims more life than any other cancer, breast cancer, prostate cancer, and colon cancer combined. And the 5-year relative survival rate for localized, meaning that when the cancer has not spread, is only 56%.
And that's 5 years.
5 years.
56%.
Correct. And the 5-year relative survival rate for all stages of lung cancer is only 19%, which is very, very alarming, but not surprising because lung cancer typically is diagnosed at a late stage.
Later stage.
Yeah.
And so, doctor, so lung cancer can be broken out into 2 buckets, if I'm not mistaken. So non-small cell lung cancer and small cell lung cancer. What is the difference between the two?
Essentially, this is really just what it looks like under the microscope. So, when a pathologist looks at the cancer under the microscope, they see features that look like small cell. These are smaller cells. They have this appearance we call oat cells, and that will tell them that it's a small cell cancer. And if it's not small cell, then it would be called non-small cell. But non-small cell is also subdivided into other types: adenocarcinoma, squamous cell cancer, large cell cancer. These are all types of non-small cells. So it's not really just 2. I mean, there's many different types. And these days, we really not only look at the type non-small cell or small cell, but also we look at a lot of the molecular features of the cancer. For instance, some of them have particular mutations that respond to oral treatments. Some of them will respond to immunotherapies because they have special features on them. So even though in the old way we used to just say these 2 different types of cancers, there's probably 50 different types of lung cancer.
So Vivian, the statistics that you were sharing with us, was that lung cancer as a whole? How does it divide out if you take the small cell lung cancer and non-small cell? What's the difference in the prevalence there?
Well, the statistics that are provided is a whole.
Right.
Yeah.
Got it.
But basically 85% of lung cancers are non-small cell. 15% are small cell. And then there's a few rare types like mesothelioma, which is an asbestos-related lung cancer, and there's some rare things called neuroendocrine cancers. But essentially it's 85% non-small cell, 15% small cell.
Yeah. I was not long ago doing some interviews with a group called the Ray Pfeiffer Foundation, and Ray was a first responder firefighter at 9/11. And one of the concerns that they have is, you probably saw in the news, the fund to help these 9/11 first responders and people that were down around ground zero that inhaled a lot of that dust and debris. One of the concerns they have is that mesothelioma presents itself long after you've inhaled asbestos. And so they see all these first responders that have passed away. And I think every day you turn on the news and you're seeing, a funeral for yet another first responder. They're very concerned about the big numbers that they're seeing going forward. There's a lot of, first I want to take a step back. So when somebody presents at Robert Wood Johnson Barnabas and it's diagnosed as lung cancer, is there a percentage that's greater or not of people that have been smokers?
Yes, most lung cancers, even non-small cell and small cell, have had either first-hand smoking history or second-hand smoking history. But if you're a small cell, it's virtually 100% that you've had exposure to tobacco. If you have non-small cell, we're seeing a growing percentage of people, probably still only about 10 or 15%, but who've never smoked and had no exposure. And then there's probably still another 10 or 15% who are what we call, we use the term oligosmokers, but basically have under 10 years in their life of smoking.
I'm greatly concerned about this whole vaping epidemic, because the industry has kind of said, well, if you look at smoking cessation, it could be a step to getting off smoking, right? This vaping. But what we're seeing now is that, and I see it as almost the wild, wild west out there because there's no regulation. The FDA needs to step in and really do something about this. And now all of a sudden you see these young kids that are dying because of this vaping. So I think, do you see a lot of that coming in, or do you have maybe a lung cancer patient that might be, or somebody in their family is a smoker, and they're saying, well, what about this vaping? Can that work?
So we've had several cases of patients coming into the ER with vaping respiratory illnesses, not with lung cancer though, but they do present with respiratory issues like, trouble breathing, coughing, and stomach issues like nausea, vomiting, diarrhea. But vaping in all was supposed to be an alternative for cigarette smoking, and but also be able to give the person the nicotine, in it. But I think it has taken a whole new turn.
Yeah.
Yeah, and it was supposed to be for adults.
Yeah.
But now, as you said, with the middle-aged students, the college students, they're now addicted to the vaping.
Yeah, there certainly is a big public awareness campaign going on about that. I saw the other day a commercial where, it's two high schoolers walking down and they're talking about, the new vaping flavor called cotton candy. Well, I don't know a lot of adults that are going to vape that are going to go out and buy something called cotton candy, quite frankly. So, I think it's a concern. But getting back to lung cancer, which is what we're here today to talk about, what are some of the symptoms that a patient would present with when they show up at Robert Wood Johnson Barnabas?
So typically lung cancer does not show symptoms at an early stage, but some of the symptoms that have presented is coughing, that new cough that doesn't go away, new shortness of breath, that worsens when you take deep breathing, hoarseness, loss of appetite, significant weight loss without even trying to lose weight.
So Vivian, it sounds like you're on the very front line when these patients present. Doc, when do you get involved? Are they going through a number of tests and screening before you actually see the patient?
So one of the nice things about what we've developed at Robert Wood Johnson Barnabas Health is a program where we have a conference every Thursday morning, and we meet together with pulmonary doctors, lung specialists, thoracic surgeons, medical oncologists, radiation oncologists, radiologist and then pathologist, and we all sit in a room and we review cases. So someone will present what's happened to the patient. We'll look at the X-rays, the CT scans, and sometimes if there's pathology, we'll look at that, and we will kind of decide who is the right person to manage this. Does this patient need to go to a thoracic surgeon? Is this person appropriate for a medical oncologist? Is it multidisciplinary? Should all of us see the patient? So we get involved early on because of this conference, but typically before the conference, it would have been when someone would have presented to their primary doctor with the symptoms that Vivian just talked about. The primary doctor might have ordered a chest X-ray, saw something abnormal, sent the patient to a lung specialist, who then might have performed a bronchoscopy or a biopsy, and then if it's cancer, sent it to an oncologist.
Well, Vivian, Doc, this has been a very enlightening conversation. I think sitting around this table, we all agree that we have a lot of work to do, but I'm very confident that through the good work at Robert Wood Johnson Barnabas in Hamilton, New Jersey, we're going to get there. So thank you again for joining me. I admire the work you do, and I hope I see you back at the H360 Health Talk table for another discussion. Thank you.
Thank you, Dave, for having us.
Thank you for providing such an instructive discussion.
Thank you.